The BIONIKK trial is a French academic randomized phase 2 trial. This is a non-comparative trial. It is based on the fact that we already identified patients with metastatic clear cell renal cell carcinoma. We identified 4 molecular groups with distinct biologic features, distinct tumor microenvironment composition, and distinct outcomes with sunitinib. It was published in 2015. And what we found is we found 4 distinct molecular groups. Group 1 and 4 were patients with the poorest outcome with sunitinib. Group 1 was identified as immune desert tumors, and CCRC4, group 4, was identified as immune high tumors. But the two groups shared the poor prognosis. Conversely, CCRC2 and 3 were associated with the best outcomes, and particularly CCRC2, which was identified as a non-GEO-high tumors, very enriched in angiogenesis in these tumors. So based on this result, we constructed a signature, a gene expression signature of 35 genes, and we designed the BIONIKK trial. So BIONIKK include patients metastatic clear cell renal cell carcinoma in first-line setting without any treatment before. Patients were eligible if they had frozen tumor samples, and we identified prospectively the molecular group from these samples from 1 to 2, 3, or 4. Patients in group 1 and 4 were randomized between Nivolumab 240 milligrams every 2 weeks and Nivolumab Ipilimumab as the standard and usual dose and schedule, the combination Nivolumab Ipilimumab, and group 2 and 3 between Nivolumab Ipilimumab and TKI, sunitinib or pazopanib at the physician discretion. The hypothesis behind that is that patients in CCRC4 would respond very well to Nivolumab alone because it is an immune high tumors, and in CCRC1 it is they are all immune desert, so maybe Nivolumab Ipilimumab would work better than Nivolumab alone. And for group 2, since we had very good responses to sunitinib, we proposed Nivolumab Ipilimumab versus sunitinib or pazopanib. The patients were treated until progression or death or unacceptable toxicity or the end of study, defined at 18 months. And the primary endpoint was objective response rate per arm and per group based on RECIST 1.1. This is the general schema of the study. So we have 308 patients who were screened for the study to randomize finally 202 patients, and mainly in the what we say a target cohort of 163 patients. All these patients were grouped on the same platform, and a second additional cohort of nearly 33 patients were grouped on a second platform to assess this heterogeneity, inter-platform heterogeneity. So the primary endpoint, overall response rate on this target cohort of patients, 163, among which 154 were evaluable. So the distribution, group 1 was group 1 tumors were more frequent with nearly 64 patients, followed by group 2 with 59 patients, and we found a very, very small group of patients in group 3 with only 7 patients. So the main result in the primary endpoint was objective response rate. In group 1, we found with Nivolumab a response rate of 20%, 20.7% in group 1. From Nivolumab Ipilimumab, 39% of response, and in group 4, which are the poorest prognosis group, the both arm did better because we found a 50% of objective response rate for Nivolumab alone with 7.81% of complete response, and for the Nivolumab Ipilimumab, we found a 53% of response with 11.8% of complete response. In group 2, we found TKI with an impressive response rate of 53.8% and Nivolumab Ipilimumab 48.3%. So we found a interesting group in group 4 with a high response rate to Nivolumab alone, and group 2 a high response rate of TKI. And we saw also that Nivolumab Ipilimumab performed quite well in all the cohorts. In terms of PFS, which was a key secondary endpoint, in group 1, Nivolumab Ipilimumab median PFS 8 months, Nivolumab alone 4.6 months. In group 4, Nivolumab Ipilimumab 12.2 months, and Nivolumab alone 7.8 months. And in CCRC2, in group 2, the median PFS was not reached for TKI and was 10.4 months for Nivolumab Ipilimumab. The group 3 was composed of only 7 patients, so we did not look at the median PFS for these patients. Overall survival was not mature with only 60% of events. So these are the main results. When we look at the median time to response, nearly the vast majority of patients had their first response at the first CT scan, even in the group of Nivolumab, which was not so obvious to find this response so early. And for TKI, we have a specific group of patients who respond very later with TKI in group 2, more than 10 months for about 30% of the patients with TKI. And the duration of response were very prolonged for each patient, each group, and each treatment arm. In terms of toxicity, we did not find any new safety signal as compared to published data. And in the presentation, I also show very exploratory results when we looked at the distribution of the immune cell composition by gene expression, by transcriptomic data on 84 patients. We found again that the group 4 is highly infiltrated and more infiltrated than the other groups, and particular for cytotoxic T lymphocytes. It probably explains in part the result of the Nivolumab alone arm, which has a very high response rate. We have a huge ancillary program, including in situ protein expression, transcriptomics, an intelligence artificial program, also on digitalized FFP slides, and a large part of blood biomarkers. So, in conclusion, if we have to conclude the trial, this is the first randomized clinical trial based on prospective and real-time molecular assessment to guide therapy in frontline CCRCC. This CCRCC group enables to enrich response rate. We have a higher response rate ever seen with Nivolumab in group 4, with durable responses. In patients in group 1 tumors, combination of Nivolumab and Ipilimumab seems to be necessary to improve the outcomes. In CCRC2, TKI provide very high response rate, and the median PFS was not reached. I did not mention the median follow-up was 16 months. And interestingly, in this group 2, we found also the highest complete response rate with Nivolumab Ipilimumab. So very interesting group too. So the BIONIKK trial provides evidence that on the best candidates to receive TKI, Nivolumab alone, or Nivolumab Ipilimumab. A biomarker program including transcriptomic analysis, in situ protein expression, and analysis of circulating immune cells is currently ongoing. And I hope this result will be available very soon. The main results of the trial, and I mentioned to you that it is an academic trial. The sponsor is Arctic. It's an association based on our hospital in France. And this work was made possible thanks to Arctic and all the 15 centers in France and the lab team who participate in this trial. So